Alert Medic 1 respond. Box area 19 dash.
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
All right, we ready?
Yeah, I'm good.
All right. Welcome back, everybody, to the Alert Medic 1 podcast. My name is Ken Sanner. This is...
Hey, I'm Mustafa Siddiq, guys.
David Wittberg.
And our special guest today, who actually is joining our team, right? Brian Spoolhoff.
Hey, how's it going? I'm very happy to be here.
So you guys all know us, but just to introduce Brian again, he was one of our very first guests. He's a doctor of pharmacy. And today we're going to be talking about part 2 of our traumatic brain injury discussion. So we're going to get into a lot of different aspects with it. And I'm excited to see where it goes. So we want to start off with a little bit of a review of the last podcast we had on this, just a quick outline of some of the basics. I'll throw it over to you, Brian, if you want to touch on, what traumatic brain injury is, and then we can kind of talk about how that relates to our EMS practice.
Yeah, absolutely. So just a quick review of traumatic brain injury, at least from a pharmacist's perspective and in my history as a neurocritical care pharmacist. Traumatic brain injury is a broad definition. It includes anything from, concussions or concussions from football injuries and all that kind of stuff. But I think what we're focused on here is really severe traumatic brain injury. This is things from car accidents, from maybe gunshot wounds to the head, things along the nature of that. And one of the key things I think that I wanted to review going back to this topic is the concept of the Monroe Doctrine, that the brain is in a closed space, the skull, and inside that skull you have blood, you have CSF, which is the fluid that kind of surrounds the brain, and you have the brain tissue itself. And so between those three things, any one that increases your intracranial pressures. And that ultimately becomes the thing that we try to ameliorate the most in acute injury outside of all the other supportive care. So, yeah.
Okay, great. So I think that's kind of a good place to start when we think about increased intracranial pressure. Last time we talked about mannitol, we talked about hypertonic saline, some of the methods we use to decrease that increased intracranial pressure. One thing we touched on at the end of the last episode was hypertension management, and how that wasn't really as much of a primary concern as maybe hypotension management. Hypotension is definitely a killer in these patients, right?
Yeah, absolutely. So going back to that concept of the Monroe Doctrine and increased intracranial pressures, what happens in traumatic brain injury is your brain's trying to fight this increase in blood pressure. Or I should say pressure inside the brain, which is kind of closing off the ability to perfuse the brain. So what we want to do is try to increase overall our mean arterial pressures, because the more blood that's going to the brain, the less that's going to get cut off by the intracranial pressure. So when you have hypotension, you end up decreasing the perfusion to the brain. In some cases, we may try to augment somebody's blood pressure in order to increase the overall perfusion. I think getting to your question is how do we do that? Compared to something like sepsis, which is a distributive shock and is a decrease in actual blood volume, or maybe decrease in tone. Patients with traumatic brain injury, outside of maybe blood loss from the trauma itself, have normal volume, and so you have to increase the pressure, typically augment that if they're getting hypotensive with agents such as norepinephrine or phenylephrine. And there's no good data about which one to choose, but if we borrow from the surviving sepsis guidelines and from other data that I've looked at that, our preferred agent typically is norepinephrine.
So I guess the key there would be getting vasoconstriction, right? Because you're losing neural tone. That would normally, keep our...
So I think one of, just to elaborate a little bit on what Brian said, I think it would bear stating the simple formula that I love, that I use in the ICU every day, which is what Brian's been talking about the last few minutes, which is your cerebral perfusion pressure is equal to your mean arterial pressure, your mean blood pressure, minus your intracranial pressure. And if you look at that very, very simple formula, you can see that if intracranial pressure increases, we have to keep the mean arterial pressure, the blood pressure, at a normal or even higher range to maintain cerebral perfusion pressure. So to go back to your specific question, you said vasoconstriction. Yes, that's one way to raise your mean arterial pressure, your blood pressure. You can also give more volume. So all the things that typically can raise blood pressure, volume, vasoconstriction, increased inotropy, all of those things can be harnessed. The end result of whatever you do has to be to raise the mean blood pressure, the mean arterial pressure, to overcome the increased intracranial pressure and maintain adequate levels of cerebral perfusion.
Yeah, that's absolutely correct. I think historically we've looked at ICP as our goal of management, and really it should be CPP, or cerebral perfusion pressure.
And to elaborate on that statement a little bit, one of the challenges for EMS is that we typically don't monitor ICP. We're not putting in Camino catheters. We're not putting in ventriculostomies. I could see a situation where we have some listeners that are engaged in interfacility critical care transport that are moving patients from an outlying hospital to a tertiary care center that may have one of those devices in place. But clinically, our barometer for what the ICP is in the field is the clinical exam, the mechanism of injury. And we have to have a kind of we have to do a good exam. We have to kind of look at the mechanism of injury. We have to suspect ICP when we see somebody that's involved with the right mechanism, with altered mental status or depressed mental status. And if you look across most state protocols, there's always in bold at the bottom of the trauma section the imperative to maintain some sort of minimum blood pressure for patients with traumatic brain injury for this very reason. We just don't have the ability typically to measure ICP in the field.
All right, great. I think that's a really good discussion. I want to talk about something that is maybe sort of a myth that surrounds TBI management. When I was in paramedic school, it was really, really hammered down that if you had somebody with any kind of a head injury, you should never, ever give any dextrose because that's going to cause necrosis in the brain, and you're going to end up having a really bad day, or at least the patient will. And I just was wondering if there's any truth to that.
So again, from a pharmacist perspective, I agree that is definitely a myth. I think where that myth comes from is the administration of D5W, or dextrose 5% in water, is free water, which means you end up just giving all this extra water to the patient, and you end up diluting out the patient's sodium. By doing that, by diluting out somebody's sodium, you're going to decrease the serum osmolality, and you're going to end up causing a shift of fluid potentially into the brain. So that's where that myth comes from. Really, what it means is that dextrose alone is not harmful, but free water is what's harmful to a patient. So if you're giving somebody D5NS, that's not necessarily harmful. If somebody has a glucose of 60 or 40 and you have to treat their hypoglycemia, give them the D50, because that's going to be worse in the end. Long term, what you want to try to avoid giving patients is free water with no replacement of sodium.
From a hospital clinical perspective, couldn't agree more. Dextrose is absolutely critical for cerebral function. Hypoglycemia can be catastrophic in and of itself, independent of traumatic brain injury. I think we all know that hypoglycemia, particularly at the extremes of age, can cause long-lasting adverse problems with regard to brain function. Hypoglycemia can mimic stroke. It can cause sustained stroke-like symptoms in adults and elderly patients. So it's absolutely imperative from a practical boots-on-the-ground perspective during the course of treating a trauma patient with TBI to go through and do your comprehensive assessment, including looking for the reason they may have actually crashed their car. Was their glucose 25? And correcting that expeditiously. And like Brian said, we would typically, now in EMS, we're moving away from concentrated kind of D50 preps to more of the slower, larger volume infusions of a more hypotonic solution. I would argue for a traumatic brain injury patient in the field, I would use the more concentrated D50 to rapidly correct them. I'd be a little less concerned about overshoot hyperglycemia. And I would be concerned about giving them larger volumes of a hypotonic dilute fluid that could cross the blood-brain barrier and cause worsening cerebral edema. So it is absolutely imperative to check a finger stick on these patients. It's absolutely important to treat hypoglycemia. It's very important whenever you encounter a trauma patient to think about, how did they get themselves in this mess? Was there a medical emergency that precipitated this, that caused them to fall down the stairs, veer off the road? In general, we don't want our patients to be hypoglycemic. We don't want them to be hypotensive. And we certainly don't want them to be hypoxic. That's the last thing I'll say, kind of in the triad of treatment priorities for patients with traumatic brain injury in the field. It's well known that one episode of hypoxemia, sat less than 90% or so in a patient with traumatic brain injury, increases their mortality risk by well over 100%. So to me, that's kind of the triad of things that I focus on.
And I think that's 2 points I kind of take away from that. One, I think it's really interesting, and I'd be curious to find out how many of these myths and misnomers are out there that were taught as EMS clinicians, or at least that we had been. We've gotten a lot more into evidence-based stuff over the past, 5-10 years, but I'm sure there are still a lot of, myths out there. And then the other thing is, I think this is a good segue to talk about airway management in these patients.
If I could just go back to kind of the myths that we hear about over and over in paramedic training. So again, one of our missions here at Alert Medic One is to elevate the educational content of our listeners and make everybody better pre-hospital care providers. When we talk specifically about the myth of dextrose and head injury, what that is, in my opinion, is somebody tried to very quickly deliver content without maybe the time or the ability or the knowledge base to expand on the concept of sodium and water disorders in the body. So it's not just, dextrose is bad equals worsening, traumatic brain injury. It's taking more time to explain what does an infusion of a hypotonic fluid like D5 water do to total body sodium, and like Brian said, osmolarity, and how does that cause fluid shifts across that semi-permeable membrane, which is the blood-brain barrier. I think for the typical paramedic EMT, that's a heavy lift. That's something that those of us that are fortunate to go through a college education, PharmD training, medical school, we spend hours talking about fluid shifts and tonicity of fluids and the effects of what that does as far as things moving across the blood-brain barrier. I don't know that a lot of folks in EMS education understand those concepts. I don't know that we have enough time in our typical curriculum to talk about those things. I think we very quickly teach people about IV fluids and the do's and the don'ts, and this kind of myth of dextrose equals worsening head injury was just born out of the fact that we only have so much time to deliver content and get people prepared for their exams and get them out in the field. And again, I think it's a really nice kind of thing to state, because that's our goal here, is to kind of maybe fill in some of the blanks and as we dispel myths.
I mean, I can't agree enough. And that kind of like where you explained that myth is born, there's hundreds of those myths, right? Like one of those myths that Ken and I have talked about is CPAP, right? And like how it actually works, and we don't need to discuss it like on this episode, but yeah, you're right. It's a tight curriculum, right? And I mean, I think Ken would be the best that knows it's a tight curriculum where as someone that leads as an instructor, it's a tight curriculum, and the background that many people have is very variable, right? I'm just thinking of my paramedic class. You had people with, and not knocking anyone with high school education, but like you don't have the background to even have the discussion of osmolarity when you don't understand fluid dynamics. Right?
I mean, what is a semi-permeable membrane? Let's start
right.
there. And how many of us remember in college or wherever in our education, we did that experiment, and there was a semi-permeable membrane between water and salt water, and you had to measure. One of the we've talked. This is a pretty related tangent, but we get into these tangents when we do our recordings. We've been talking about this locally. Is how do you elevate the quality of EMS education? And this is a great example. And I think one of the solutions to this problem is bringing in relative or subject matter experts for the thing that they are teaching. And rather than having a lead instructor go through PowerPoint after PowerPoint after PowerPoint, perhaps when you teach somebody about traumatic brain injury, you bring in somebody like Brian, who is a neurocritical care pharmacist, to deliver the content if they're available locally, and you can tap into that resource. Perhaps if you start to teach somebody in your class about DKA, you reach out to maybe there's an endocrinologist who at one point in their life was involved in EMS and wants to come back and give back to the EMS community. So, I think that's one of the strategies too, is I think too often we rely on singular or, 2 or 3 educators to deliver a whole program of EMS content, be it EMT or paramedic. And one of the strategies, again, we've started to use locally, which is very obvious and intuitive, is tap into subject matter experts. If you have a medical director, reach out to them and have them help you get in contact with potential subject matter experts at your local hospitals or even in other programs across town.
Yeah, and to be honest, this is something we could do a whole podcast on, is what should paramedic or EMT education look like, because there's a lot to say on it. There's a lot of opinions about it. I think you make really good points. And one of the biggest problems we have, when we talk about a subject like traumatic brain injury, is as an instructor for paramedics, basically I'm given 4 hours on one day to cover TBI, and we may touch on it lightly again, but realistically that's a bulk of what you're going to get. You're going to get these 4 hours. We're going to talk about it. We might touch on stuff on a lab day. You're going to take a test, and then we don't talk about it again for the next 6 months.
And you have to teach to that test to a point,
right.
And to whatever learning objectives are part of that. You have to teach that, because the student, even if you give a great lecture on TBI, if you don't hit those points, and this is something I run into, because I'm the first one to say, sometimes I go off on a tangent when I'm lecturing. Mm-hmm. If you don't cover all those points, you see it in the students, and it's not their fault, because as an instructor, you didn't cover the points that were supposed to be covered for that specific test, and whatever program the paramedic program follows.
So do you want to get back into the subject at hand, TBI?
Yeah,
so we talked about the danger of hypoxemia, hypoxia. We talked about the danger of hypotension. We talked about the myth of administering dextrose and hypoglycemia that needs to be treated. Mm-hmm. Where do we want to go next?
Yeah, I think the most natural segue here is to go from hypoxia into airway management. We want to talk a little about RSI in regards to TBI. So I think that's a pretty fair place to take the discussion.
And definitely go back to our airway management episodes for an in-depth airway management review.
Oh, absolutely, yeah. So, all right, so... RSI stuff. I guess the most important thing to start with is, when do we need to facilitate a drug facilitated intubation on somebody with a TBI? I think that's a good place to start.
So, just my clinical 2 cents, I hear this in my head over and over. We always hear the GCS less than 8 intubate. Is that something you guys have heard?
Absolutely.
Yeah.
That's what I know as a pharmacist.
Yeah. I wish it were that straightforward. I don't know also how accurate our providers are in the field at quickly calculating an accurate GCS for a profoundly injured patient lying in the street. I think the decision regarding when to secure an airway, I again, in my 40s and over 10 years into being an attending physician and very into this stuff, I still constantly refine that decision. And it's a very case-by-case driven decision, and it has to be a very careful decision as far as when to do it, what tools you have available, what medications you have available. I would put as a tenet of whatever decision you make, that the avoidance of hypoxia has to be way at the top of your considerations, and then we can certainly get into discussion regarding the technique and the medications. Maybe do you want to focus a little bit on medication selection?
Yeah, well, so I definitely want to do inclusion criteria, like physical symptoms that would give us for a TBI, and then go into that. Yeah.
So feel free, you guys, to do this as well as I do. But number one, let's just stick with the mantra: GCS less than 8, intubate. Somebody has a profoundly depressed mental status and cannot protect their airway. Their tongue is obstructing their airway. Secretions are obstructing their airway. They have a snoring, ineffective respiratory pattern, ineffective chest rise and fall, hypoxemia, a soiled airway because of vomitus or blood, that just, for any of those reasons, those would all be reasons I would consider securing a patient's airway, provided I was in a position to do so, and I had the tools I needed to do it effectively the first time, and I had the medications that I needed as well.
So I think that's a good segue into talking about the actual meds that we use.
Sure.
Right, and we are going to be doing a dedicated RSI episode, but just for the sake of conversation right now. And Brian, I think this is where we're going to hand it off to you. So from my understanding, you have sedatives and you have paralytics, right? And then maybe if we could dive into the different agents and then briefly touch on how the different paralytics work, like polarizing versus non-polarizing.
So yeah, definitely. So I can go through some of those, but I just want to touch on one thing about GCS. And one of the things that was mentioned was, the GCS less than 8 and how good are individuals at assessing GCS or variability. I just want to point out that GCS has known inter-rater variability, whether it's in the pre-hospital setting or even in the hospital setting. You can ask 2 nurses or 2 providers, and you may get 2 different GCS numbers. So always keep that in mind when you're using strict cutoffs. And ultimately, I'm going to defer to a clinician who's familiar with whether they think the patient needs to be intubated or not. To talk a little bit about the medications, I would actually break it into 3 kind of topics. There's the kind of pre-treatment medications, there's the sedatives, and there's the paralytics. I will put the caveat that not everybody needs medication to be intubated. Certainly, it's going to be more if you think you're going to have trouble intubating a patient, whether they're combative and what kind of muscle tone is going on. So in terms of pre-treatment, there are 2 agents that kind of get brought up frequently with traumatic brain injury. The first being lidocaine and the second being fentanyl. So briefly, I want to touch on lidocaine. This is something that's been used historically with the thought that lidocaine does suppress the cough reflex. So when you're intubating somebody, there may be coughing. Coughing leads to increased intracranial pressures. Therefore, if you can blunt the cough response, you can blunt increases in intracranial pressures. There's no great data to support that. There's been a couple small studies that have found benefit. There's some small studies that have found no benefit. And I'll say in my clinical practice, I very rarely use lidocaine for pretreatment. The other would be fentanyl. Here, it's the same kind of concept that pain can increase intracranial pressures. Intubating or being intubated can be painful. Therefore, give a little bit of pain medication, and that can help blunt the response. Again, there's no great data to support that. I'm not against giving a little bit of fentanyl, but in most cases, when we need to intubate somebody, I'm more focused on the sedation and paralytics if needed. Any questions or thoughts on that at all?
Do you have just a rough dose for what you would give for that fentanyl if you're delivering it? And would that wouldn't be replacing a sedative, right? That would be in tandem with.
For fentanyl?
Yes.
Yeah. Fentanyl, there's a range of doses that I've seen reported. Typically, I'm thinking in the more like 100 mic to 200 mic, depending on the size of the patient. If you have a pediatric patient, less, but somewhere in that range. And it does not replace sedatives. No, this would be in conjunction with sedatives if you decide to give it.
So for those of our listeners that may have taken an airway course back in the day, there's a mnemonic that was taught: load lidocaine, opioid, atropine, defasciculating agents. I think at some point we're going to talk about the myth of atropine and how defasciculating agents are just not used anymore. So what you're talking about is the LO at the top of the old LOAD. Brian, question for you. Does lidocaine, you talked about it suppressing the cough reflex. Does IV lidocaine provide any degree of glottic anesthesia? And I'm not talking about topicalization where you would spray lidocaine through an atomizer, but does an IV dose of lidocaine provide any generalized or glottic anesthesia?
What I can tell you is that lidocaine has been used for pain management. I'm not familiar with it being used in anesthesia. I'd have to look into that.
Okay.
But it does have some benefits in terms of pain management.
And I think we're going to touch on this later, but you'd mentioned lidocaine. I find a lot of clinicians aren't using it because of the lack of evidence that it does reduce ICP during an intubation attempt. I kind of look at things as risk benefit. Are there any risks associated? So there doesn't seem to be a proven benefit with ICP reduction in any sort of robust studies. Are there any risks where you say, hey, you know what, I'm going to give it just because it may keep the ICP at a normal range, or it may reduce the ICP? Is there any risk of giving lidocaine?
Yeah, no, that's a great question. Certainly, lidocaine, when used intravenously, is typically used as an antiarrhythmic. And with a lot of our antiarrhythmics, they can also be proarrhythmic if not used for the right indication, or if there's some underlying electrical disturbances within the heart. Although lidocaine is generally a safer antiarrhythmic, it still has the potential to cause some arrhythmias. That's not really my specialty area in terms of some of that cardiology stuff. I'd have to defer to some of my colleagues on that.
Okay. So we talked about lidocaine and fentanyl as pre-medications. Do we want to get into our sedatives?
Yeah, absolutely.
Yeah. So from a sedative standpoint, I would say there are a few common sedatives. There's a few less common, and then there's ones that nobody ever really uses anymore. I would say the most common sedatives that I see used for intubation are Atomidate, Propofol, and Ketamine. Less frequently, I certainly see benzodiazepines, and there have been barbiturates that were used historically. Barbiturates are no longer used because of drug shortages and cost associated with rapid-acting barbiturates. Benzos are usually avoided because, most of the time we underdose our benzodiazepines for induction. Just to give you a example, the average patient needs 0.3 mg per kg, so you're talking somewhere in the 20 to 30 milligrams of Versed, and we don't often give that much Versed to a patient.
We don't carry that much. I'm trying to think of our local units here may carry 6 to 8 milligrams of Versed. I don't know how much you carry in your jurisdiction.
20.
Oh, you do carry 20?
Unit,
okay.
Yeah.
Oh, so you're carrying concentrated, probably the 5 milligram per
5
1 ml.
5 and yeah.
And you're probably also carrying the 2 milligram per 2 ml.
Yeah,
just concentrated.
It's actually it's 5 and 2 of
Okay.
what we carry.
Okay.
Yep.
I think that's
and not everybody's going to carry that much Versed on the EMS. And I'll say even in EDs, we don't have necessarily, that's not practical to drop that much midazolam. So that leaves us with Atomidate, Propofol, and Ketamine. From a TBI standpoint, I'll say that most people like to jump to Propofol. And there's a reason for that. Propofol is somewhat neuroprotective. Propofol does drop intracranial pressures. There was a study, and I don't have the citation in front of me, but it drops ICPs of about 14 or 15 millimeters of mercury. So that's definitely helpful for our patients that have traumatic brain injury. But with anything, any benefit often comes a risk, as we were talking about before. And Propofol's big risk is it decreases blood pressure. And if we remember that cerebral perfusion pressure equation, which is MAP minus ICP, it's a balance. You may be dropping ICPs, but you may also be dropping MAPs. So in patients who are already on the edge and maybe a little bit hemodynamically unstable, you might want to try to avoid Propofol. And then sorry, go ahead.
No, so I guess the similar argument would be made for benzos too, right? That because they, especially at that high dosing, they definitely pose a risk for
hypotension.
Yeah, hypotension.
Yeah, I can tell you I see hypotension with almost every patient that gets put on Propofol. And so it's always a balance. So Propofol certainly works if you have a hemodynamically stable patient, but always be cautious that you may end up causing bradycardia and hypotension.
Or I sometimes use, and I think a lot of us use our drugs for other side effects. So, we talked about Propofol typically lowering blood pressure. I think a lot of, as I recall, the patients with traumatic brain injury that I've intubated in the field, many of them have had severe hypertension with bradycardia. And so I've harnessed the Propofol both for being a good induction agent, sedative, reducing blood pressure, reducing ICP, and just its rapid onset of action.
You give Propofol, like you've given Propofol in the field?
I carry propofol
That's so
in
cool.
my vehicle.
I wish I worked more
but
closely
it's
with
not
medical
available for
directors.
personal use.
Of course, I would hope not. Only White Claws, right?
If it's white, actually, we'll just move on here.
Yeah.
So the last agent was ketamine. And ketamine is one of those that have historically said have been reported to absolutely do not use in traumatic brain injury. And the rationale behind that is some case reports that came out many, many decades ago. And I couldn't tell you exactly when those were all published, but what they found was that ketamine may increase the risk of intracranial pressures. And therefore, it based on those small case reports, it was automatically deemed inappropriate for use in patients with traumatic brain injury. Turns out that's probably not the case. Even if it does cause a small increase in intracranial pressure, the benefits, other benefits of ketamine are that it increases MAP. So it's kind of think of it as the opposite of propofol in terms of some of its hemodynamic properties. It actually increases blood pressure that may balance out some of the increases in ICPs. So ketamine, the other benefit, of course, is it has an analgesic property associated with it. And so if you want to go down the route of believing the literature that some analgesia may help reduce ICPs or prevent increases in ICPs, then ketamine might actually be a good option in some of these cases.
Brian, can you talk about Atomidate also?
Oh, yeah, absolutely. Atomidate. So Atomidate is certainly an agent that we can use in traumatic brain injury. The huge benefit with Atomidate is that it's pressure neutral. Neither raises or decreases the blood pressure. The only caveat that we see with Atomidate is it may cause some adrenal suppression or some decrease in immune function long term. Ultimately, we don't really worry about that for one-time doses. That was something that came out of literature and continuous infusions of Atomidate.
Okay, so we've talked about pre-medication with lidocaine, whether or not that may or may not be helpful for suppressing or keeping ICP neutral. We talked about pre-medication with an opioid like fentanyl, again, because of the noxious stimulation to the airway and blunting any rise in ICP. We talked about a number of sedative agents or induction agents, Atomidate kind of being pressure neutral, Propofol causing both a reduction in blood pressure and ICP, and ketamine kind of being the opposite of Propofol and in recent literature being kind of deemed safe for use in patients with traumatic brain injury.
Yeah.
Just before we get into discussion about paralytics, any comment, Brian, on and this brings us back to the field and practicality, storage requirements for any of the, and maybe why don't we do paralytics first? And then I'd be curious about your thoughts about storage requirements, extremes of temperature in vehicles in hot climates and cold climates for all of these agents. And are any of them better than another, or any more robust at kind of, or have a longer shelf life in a medic unit?
That's a great question. So talking a little bit about shelf life and some of those things from a sedative standpoint, most of those agents are to be stored at room temperature. There is some kind of data on extremes of whether it's cold or warm. That's all information that's available in the package inserts. Typically, the highest I've seen is around 80 degrees. The lowest is being around in the 80 degrees Fahrenheit. The lowest being usually in the 60s for temperature. In some cases, for example, Propofol, just in my research and talking with some drug companies, Propofol can be refrigerated, although it's not in the package insert FDA approved to be put in the refrigerator. So those are some considerations. It comes into much bigger play when we start talking about the paralytics, I think. So if we want, we can talk briefly about storage requirements with paralytics. The two that become problematic is Vacuronium and succinylcholine. Those generally are stored at refrigerated temperatures. And once they come out of the refrigerator, you have a shortened shelf life of somewhere between 30 and 60 days, depending on the manufacturer and the particular brand and the drug that we're talking about. That makes it very difficult to store these, not just in the EMS ambulances, but also when we're thinking about where we're going to store throughout a hospital, if we're going to have RSI kits, things along that nature. The one that tends to be a little bit better is Vacuronium, which can be stored at room temperature and has a little bit more leeway when it comes to extremes in temperature.
Which, by the way, of the three agents, Sux, Rock, and Vec, is probably the most rarely used in the hospital, and I would argue probably most rarely used in the field outside of critical care transport.
And that needs to be reconstituted, right? Generally, Vacuronium.
Oh, which one? Vacuronium?
Vacuronium.
Vacuronium. So that's the drawback of Vac. Vac requires reconstitution.
For our listeners that don't know what reconstitution is, it comes in the form of a powder that needs to be turned into a liquid.
Yeah. So it as opposed to succinylcholine and Vacuronium, which are ready just to be drawn right out of the vial, Vacuronium you dilute with some solution. I will say it's actually pretty easy if you have flushes, although I'm not supposed to recommend using flushes because flushes aren't FDA approved for reconstitution. But if you have a standard 10 milligram vial, you have a 10 ml flush, you reconstitute it right down to a 1 milligram per ml concentration, which is super helpful.
Do you want to talk a little bit about the paralytics, Sux and Rock?
Yeah.
With regard to TBI?
So, which ones do you want to talk about?
Sux and Rock.
Sux and Rock. Succinylcholine is a depolarizing paralytic. So what does that mean? So your muscles have some, what I would say are gates essentially on them, that when certain things bind to those gates, it allows the influx or bringing in of sodium. So one of the gated channels that you have on your cells are sodium gated, and you have ion gated and ligand gated. And so for ligand gated channels such as acetylcholine will bind to that receptor. It opens up, sodium flows in, that cell becomes more positive because sodium's a nice positive ion that increases its excitability, and eventually you hit something called action potential, which allows all of the fun ions to flow in and out to cause a downstream effect of muscle contraction. So succinylcholine essentially is acetylcholine. It's actually two acetylcholines bound together. And so succinylcholine will bind to that acetylcholine receptor, cause the influx of sodium. It will cause potassium to leave the cell, and you ultimately get this what happens is the cell depolarizes, and you initially contract, and then because it's kind of locked open by the succinylcholine, it relaxes and then cannot recontract. Does that make sense?
Mm-hmm. Absolutely. And that contraction you get with the succinylcholine, I'm sorry, that contraction you get.
Go ahead.
Can you hear me now?
Yes. Sorry.
Okay. That contraction you get with the succinylcholine, that's referred to as fasciculations, correct? And that can be painful for the patient, assuming they're in a position to be able to comprehend what's going on, which hopefully you've sedated them, and they're not, but...
Yeah,
it certainly can be painful. Sorry, go ahead.
Yeah, I mean, I have so many like golden tenets. I think like everything is a golden tenet, but I think that awareness during the administration or the continuous infusion of a paralytic is a can never happen event.
100%, 100%.
And so let's just put this in practical terms, since we're talking to our EMS community. You know, if I administer a paralytic and intubate somebody in the field, I need to be watching them with my own eyes for the half-life and beyond of that paralytic to ensure that they don't have any awareness. So typically when I perform a drug-facilitated intubation or rapid sequence intubation and give a paralytic in the field, I put as a personal mandate on myself that I have to be with that patient to ensure that they have no awareness until the duration of that paralytic wears off. Again, imagine being strapped to a backboard in head blocks with a collar on, being loaded into a helicopter, all of the ambient chaos and noise around you, being completely locked in and paralyzed with your traumatic injuries and all the pain associated with that, and having awareness. So to go back to what you initially said, is that fasciculation painful? I sure hope that the person has no awareness and has received a proper pre-medication and sedative hypnotic induction agent prior to or in conjunction to the paralytic. So to me that question is it can never happen.
And that's actually something I was going to bring up on the RSI episode when we get around to a standalone RSI episode. Is essentially, if you have somebody that you paralyze and you do all this stuff to, and you don't properly sedate them, you're torturing them. That's a horrible. I can't even imagine. It's like those people that are awake for surgery. Like
it's the diving bell and the butterflies of the book. If you want to read about being locked in, it's the author was actually an editor of one of the, it was Vogue, or I'm gonna mess this up, a huge journal, fashion journal, and he suffered a stroke and he was locked in, and it kind of describes the experience of being locked in and only being able to twitch your eyes. There are very, very good ways as a clinician to pick up as you examine and reassess your patient whether or not a patient is having awareness. Typically, they'll become very tachycardic, hypertensive, diaphoretic. There are certain monitors that are actually used more in the hospital setting to measure or alert us to a patient being aware. But awareness under paralysis, in my opinion, is a never can happen situation. And I think the EMS pre-hospital realm is it's something we have to be very aware of, particularly as we get into advanced scope of practice, especially as we start, opening up and developing RSI programs. I think this is something that needs to be stressed, particularly if we're using a longer acting paralytical like Vacuronium, which we kind of quickly tabled in our discussion a little while ago. I'll let Brian speak to the duration of action of succinylcholine and Vacuronium, and why those might be preferential over Vacuronium for this very reason, is avoiding awareness under paralysis.
Yeah, I think that's very well said. And certainly there's been cases in recent, you can read some stories of some cases where some individuals were given a paralytic and not adequately sedated, that led to some outcomes. So it's one of those things that definitely sedate, then you want to paralyze a patient. So to get to your point about like length of action, so succinylcholine, the reason why it can be viewed as kind of one of these prototypical drugs for paralysis is because it has a very, very fast onset, typically less than a minute. Within 15 to 30 seconds, you're starting to see the patient's muscles relax. And then it only lasts for 5 to 10 minutes. And that's because, like I mentioned before, succinylcholine is essentially just two acetylcholines kind of bound together. The body has some chemicals, acetylcholine esterase, that will rapidly break that down. That's very different from our non-depolarizing agents, Vacuronium and Vacuronium. So Vacuronium often gets kind of referred to as kind of similar to succinylcholine in terms of some of its effects, because it is very rapid acting, typically within a minute, maybe a little bit longer, and then it lasts a short period of time, although longer than succinylcholine. It has a half-life or a length of action of about maybe 20 minutes to 35 minutes, kind of in that range. The benefit here of using something like Vacuronium versus succinylcholine is that Vacuronium and non-depolarizing agents don't cause that shift of ions in and out of the cells. So when you have that with succinylcholine, you can actually raise somebody's potassium, because the potassium is inside the cells. You're opening that up. The potassium is rushing out. And in certain patients, you may actually cause hyperkalemia. You don't get that with Vacuronium. And I guess the last agent to kind of talk about that would be commonly seen would be Vacuronium. Now, the benefit of Vacuronium over Vacuronium in certain cases, and this is maybe not necessarily the traumatic brain injury or RSI, is that it has a longer length of action. So we like to use that typically in patients who are maybe having shivering when they're we're causing induced hypothermia, things like that. But certainly you can use it for RSI. The problem there is it just takes longer to kick in. Sometimes 3 to 4 minutes, lasts a little bit longer, maybe 30 to 40 minutes, and you have to reconstitute it. So that's one of the drawbacks there of Vacuronium.
Brian, what's the mechanism you mentioned? So for there's this layer depolarization, right? What's the mechanism for the non-polarizing agents?
Excellent question. So the non-depolarizing agents actually still bind to that acetylcholine receptor, cause it to block acetylcholine from being able to bind. So remember, acetylcholine binding to this receptor causes contractions. With succinylcholine, it binds, it initially causes that contraction, but then blocks it from continuing on. With the non-depolarizing agents, it blocks acetylcholine from binding without causing that initial contraction.
So they're both acting on the postsynaptic cell then, right?
Say that again?
Are they both working on like the postsynaptic cell, or is anything working on, so because there's depolarization, right? So it's all postsynaptic, right?
Yeah, this is postsynaptic, correct.
Okay.
Question for you. So I'm actually trying to sort this out in my own personal practice, both in airway management in the field and in the hospital. I'm going to say a word, Sagamidex. There's a reversal agent for Vacuronium, for non-depolarizing paralytic Vacuronium, that is not available for the shorter-acting succinylcholine. Have you come across use of Sagamidex, which is the antidote, if you will, for Vacuronium? Any experience that you want to comment on in airway management as it pertains to general airway management or intubation of TBI patients like we're focusing on now?
Yeah, I can briefly talk about Sagamidex, and I'll preface it that from a pharmacist perspective, there's some bias, I would argue, against Sagamidex because it's a very, very expensive agent. It does a great job. It definitely reverses Vacuronium. It does it very quickly. And certainly that's beneficial for the patients who maybe you're having trouble getting airway management and you have to let the paralytic wear off. It's certainly beneficial, certainly in maybe the post-operative standpoint when you want to take patients off of the, you want to extubate them, get them ready to go and out of the PACU so that you can get the next patient in there. That makes sense. But ultimately, for me, when we're intubating a patient, unless something goes wrong, I would just continue to sedate them and let it wear off rather than using more Sagamidex.
Unless something goes wrong. Words I've never heard in EMS.
Yeah.
I have a question kind of for the broader audience here, just something that I'm familiar with very little bit because they talk about it, when I teach paramedic in the textbook. But I haven't heard any discussion on. Today was Pancaronium. Is that something that's not commonly used? Is that kind of an outlier?
I see some head shaking. Yes, Pancaronium is not used, and there's really, I will tell you there are 3 reasons why we don't use Pancaronium. One is the easiest. It hasn't been available for a while because of drug shortage, although I haven't checked recently. 2, remember we're talking about how long these agents act. So succinylcholine in this like 5 to 10 minute range and Vacuronium in maybe a 20 to 30 minute range. Well, Pancaronium lasts an hour to 2 hours, so it really hangs around for a long time. And 3, it has some vagal vagal stimulation, so you can actually cause some bradycardia associated with it.
Okay. I was just curious. Thank you.
Great question.
I think it bears a little talking about. So we talked about just this potpourri of medications here, pre-medication, potentially with lidocaine and an opioid like fentanyl, sedative, hypnotic agents, Atomidate, Propofol, Ketamine, benzos, and barbs, which aren't used much anymore, choices of paralytics, succinylcholine, Vacuronium, Vacuronium. There is no one size fits all in this game. Every patient is unique. Every situation is unique. You're going to have a combination of patient age, patient weight, situation, hemodynamic profile, suspected ICP, and the choice of what you take out of, whether you use a drug out of one of those given buckets. Do I give a pre-medication? Do I need a sedative? Or do I just give a paralytic? Or, the combination of medications, I think, is really born out of a lot of training, a lot of experience. That said, we do have a lot of RSI programs around the country, and there tends to be these prefabricated drug selections that have been made for you, kind of for almost all comers. Here's my medical RSI package, here's my trauma RSI package. I'm curious if you guys work in jurisdictions that have those packages. And Brian, if you have kind of a bare bones, if you were to create kind of the simplified, idealized RSI sequence for a paramedic to provide in the field.
Well, so I'll preface this with I do not work in an RSI jurisdiction. However, I do know a little bit about it just from teaching it. And I think that the first thing I would say is if you're going to put someone in a position where they have the ability to do this RSI or drug facilitated intubation, you need to make sure they 100% have all of the tools to do it. So you need to have, definitely DL, maybe VL. Definitely you need rescue airways. Definitely you need, the ability to crike and all that good stuff, right? So I think that's the first thing. If I had to pick a drug...
And stellar medical oversight.
Stellar medical oversight, absolutely. And a lot of training for your paramedics. This isn't, this is something where you should be bringing people in, quarterly, monthly to practice intubations. You should have cadaver lab availability, stuff like that. Then, I think as far as induction agents, definitely you want to have the ability to, I think succinylcholine as a paralytic is your initial paralytic, but your induction sedation agents, Atomidate seems to be kind of the standard. Ketamine's getting big. I know there's still, as Brian said, still some discussion about if ketamine's a good idea for people with TBIs or not. It sounds like maybe the literature's heading in the way of maybe it's not such a bad thing. So I think that's important. But I think you should have choices too. Maybe you have the ability to have both Atomidate and ketamine. Succinylcholine, Vacuronium, I think is good. I don't think you need anything too much longer than that for what we're doing here in this state. There may be some instances, other places where you have prolonged transport times. Maybe you need to paralyze the person a little longer, but you really need to be up on the redosing of your sedative agent. I think that's very important. I don't know if any EMS systems out there are using Propofol. I imagine some are. They have it in the paramedic textbook, but not anywhere in kind of the mid-Atlantic area that I'm familiar with using it. So I don't know if that answers your question, Doc.
This is a long answer to what I thought was going to be a super short,
Sorry.
short answer. I think that a lot of programs teach like a 1-2 punch.
Yeah.
For medical and trauma. Moose, do you have any?
That's what I was going to say. So I'm going to answer your question, but first and foremost, I really want to harp on. It is my personal opinion that training, that RSI provider should know, and I know we kind of glossed over the physiology here as well, but you should know exactly what's going on at a normal physiological range so that when you give a drug that's significantly altering your ionic balance at these neuromuscular junctions, you know exactly what you're doing, so your clinical judgment is appropriate when you're giving these drugs, right? I think Maryland is now to answer your question. I think Maryland's pretty good when it comes to its RSI protocol because it gives. So I used to work in an RSI jurisdiction. I was never an RSI provider. I was usually the intubator because I wasn't cleared to give the drugs. I think Maryland's pretty good on giving diverse drugs, right? So I know Atomidate's in there, ketamine's in there, and Versed in there for sedation, and then the only one they have for initial paralysis is Sux, and then they get, I believe, Vex in there for long term, I believe.
Right.
When I worked for a very short period of time, when I worked at a critical care interfacility transport, the nurses were allowed to administer Propofol and a few other agents. Mm-hmm. But as far as what you're saying, I've never seen a clear, like if you have a stroke, right, patient who you give this, or if you have a TBI, you give this. It was just, what I always saw and I hated it because they didn't have medical dosages. They just had fluid volumes of just drugs to give per weight.
Right.
Sorry for the long
answer. No worries. Brian, any follow-up to that as far as an idealized sequence and getting back to the topic at hand, traumatic brain injury? If you were to create if a large jurisdiction came to you and said, we need to create a simplified RSI drug sequence for a patient with traumatic brain injury, what would your recommendations be?
I would say that the easiest and simplest is Atomidate followed by Vacuronium. Atomidate because the neutral on blood pressure, Vacuronium because you're not going to cause releases of potassium. It's going to be your safest. You may have to give some additional sedation because the Vacuronium is going to last around longer, but keep it simple.
Yeah, I agree with simplicity. I think sometimes we have to give some of these simple dictates to providers. I think if you ask the question I just asked Brian to a panel of PharmDs and a panel of medical directors, you may get different answers and combinations. Some people might say, ketamine, rocuronium. Others may say Atomidate, rocuronium. Some may favor succinylcholine. Some may say you're not doing RSI at all. You're doing basic airway management, because it bears noting that, again, if you review the literature, patients that undergo endotracheal intubation in the field for traumatic brain injury generally have worse outcomes, probably as a marker of their initial injury and disease and not so much of the RSI. But a lot of medical directors and systems have latched onto those studies and said, you know what, you're going to do basic airway management and get them to the hospital. So I think you're going to, if you ask 100 different educated providers what their ideal sequence is, you'll probably get 7, 8 different options in there. And I think, again, at the basic level of all this, like you guys have said, is you have to understand basic physiology, understand the physiology of somebody that's compromised. And if you are going to use these drugs, you have to understand how they work, their side effects, both good and bad, in order to make an educated decision.
Yeah, I think, the one thing I will say about Sux, and this is the way it was kind of explained to me, why a lot of times that is used as the initial paralytic, is because it has such a short acting or a short duration of action. One thing to think about when you're going to do a drug-facilitated intubation is that you're paralyzing this person. You're taking their ability to breathe away. If you are not 100% sure that you can secure that airway, you're going to have a problem, So that way, at least if you give the drug and something happens and you can't get the tube, at least you're not paralyzed for that long. Now, then again, we do have, supraglottic airways and stuff like that. So hopefully that's not a real issue. And hopefully you're not, RSIing somebody that, if you're not capable of getting that tube. But sometimes things happen. That's just kind of my thought process with that.
One of the things that I just want to, Brian has kept saying the kind of smooth hemodynamic profile of Atomidate. One of the things that I learned in my emergency medicine portion of my residency and shock trauma anesthesia portion of my residency at the University of Maryland is, yes, that's typically what we learn is that Atomidate has this very smooth hemodynamic profile with regard to heart rate and blood pressure. That tends to be in relatively healthy subjects. In compromised subjects, as are often found in the field, with other injuries that have rendered them hypovolemic, hemorrhagic shock, so forth, they may become hypotensive with any drug you give them, including Atomidate. And one of the things that I just want to say with regard to all of this is there's nothing is surefire here. No matter what 1-2 punch, pre-medication sedative, paralytic you use, you need to be doing almost continuous vital signs through this procedure. And more importantly than that is you have to, as you prepare to do this procedure, particularly for TBI patients who cannot afford to have any hypoxemia or any hypotension, you have to be prepared to mitigate both of those things immediately. So I advocate to think about, as you select your drugs and you're preparing and pre-oxygenating and doing all that, to think about, what am I going to do if they become hypotensive? Do I have a bag of fluid already spiked, or am I going to have to ask somebody to go into a cabinet and grab the bag and open it up and flush the tubing? If their sats start to drop after I've given medication and I've been unable to secure their airway with either direct laryngoscopy or video laryngoscopy, do I have my BVM right at my side with the basic airway adjunct or my rescue device? So this is a very, very complex, intricate process, and you have to have a very good understanding, like of all the things we've talked about: the patients, the physiology, the drugs, side effect of drugs. But you also have to be prepared for no patient has read the textbook. Every patient can change in an unexpected fashion before, during, or after rapid sequence intubation in the setting of a traumatic brain injury, and usually because these patients have other injuries that are rendering them hemodynamically compromised. So you should always be prepared to mitigate hypotension. You should always be prepared to mitigate hypoxia. You should always, if possible, call for additional resources and have extra hands. And I'll finish my comments by saying I love the fact that you said you weren't RSI cleared in the jurisdiction you worked, so you would often do the intubation. And I loved hearing that, because I think my observation going around the country is a lot of times the person that is cleared to do RSI is trying to do everything. They're trying to be the paramedic and get the patient on the monitor and get the vital signs and draw up their drugs and administer the drugs in a safe fashion using the 5 or 6 rights, and then perform the intubation. And I think what you described is actually a much more idealized scenario where you actually have the RSI, quote, cleared person looking at the big picture, kind of almost at the foot of the bed when we run a resuscitation in the hospital. And what do the vital signs look like? And what do the SATs look like? And the blood pressure? And let me make an educated choice if I do have drugs to choose from. And I'm going to let another person who's actually skilled at intubation do the actual procedure, focus on pre-oxygenation, head positioning, if I can move the head a little bit, and do the actual intubation procedure itself. So I love that you actually, in whatever jurisdiction you're describing, actually disconnect those two processes. They're connected, but they're physically done by two different people.
Yeah. So we're coming up on, well, we're actually already past an hour.
Oh, wow.
Brian, but I don't want to cut it short. Brian, did you have any other notes you wanted to cover for TBI?
TBI, there's certainly plenty of other things we can talk about. Certainly there's seizure management in the acute phase. There's refractory intracranial pressures and how you handle those. But those can be hour-long discussions in and of
I was going to
themselves.
say, we can always do a part 3 of TBI management.
Yeah.
Even though this was kind of like part 2 of TBI management / all of RSI, but it's good discussion.
I
it's really good.
I definitely want to do an RSI conversation because that's when I really want to dive into the physiology, right?
Okay.
And I really want to. That people really don't understand how complicated the neuromuscular junction is until someone actually talks to them about it, right? And it's so important to understand that. Because, quite frankly, I have seen people give sucks to hyper K patients, and it's not pretty.
That could be a problem.
Yeah. Doc, you got anything for TBI?
I would go back to, the 3 things. Avoid hypoxemia. Do not let a patient with traumatic brain injury have hypoxemia. A lot of our protocols now say, it's not necessary to give oxygen unless the stats are less than 92 to 94%. Mm-hmm. The exception to that rule is patients with suspected or proven traumatic brain injury. They cannot be hypoxemic. Avoid hypotension like the plague. Remember, cerebral perfusion pressure is equal to your mean blood pressure minus your intracranial pressure. And as your intracranial pressure rises, your cerebral perfusion pressure will generally fall unless you augment blood pressure. And avoid hypoglycemia, and don't be afraid to treat hypoglycemia with dextrose.
Brian, did you have any other final points apart from those?
No, I think from a pre-hospital management and even from a long-term hospital management standpoint, those are kind of the 3 most important things to remember.
Cool. All right, everybody. Thank you for listening to the Alert Medic 1 podcast today. Please check out our website, www.alertmedic1.com. Check us out on Facebook. Give us a like. Twitter @alert_medic1. And wherever you're listening to us on your podcast app, subscribe, listen, review, leave us a comment. Let us know what you think, what you want to hear. We appreciate you, everybody, listening. Have a great day.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.